Good afternoon, and thank you for joining the Partnership to Improve Patient Care for our 14th Annual Forum. I'm Sarah Van Gertruden, PIPC Executive Director and today's meeting moderator. Our chairman, Tony Coelho, brought this coalition together back in 2009 to continue to fight for people with disabilities, chronic conditions, and older adults to have the tools to make better health decisions. When Tony was elected to Congress, it was a priority for him to advance policies that would ensure others did not experience the same discrimination that he experienced as a person living with epilepsy. He went on to introduce the Americans with Disabilities Act in the House of Representatives and has fought for it to be fully implemented and enforced ever since. So without further ado, let's hear from Tony now.
Welcome to the 14th Annual Forum of the Partnership to Improve Patient Care. We have certainly come a long way. When Senator Ted Kennedy asked me to chair this coalition in 2009, our first job was to ensure that comparative clinical effectiveness research was centered on patients and people with disabilities. Today, the Patient-Centered Outcomes Research Institute is leading the way in changing the culture of research to be more patient-centered. In fact, PIPC designated people with disabilities as a disparities population early in its implementation over a decade ago. Today, you will learn more about the disability community's diligent efforts to have the NIH follow PIPC's lead by also designating people with disabilities as a disparities population, so that research dollars are used to improve our quality of life. Over the years, PIPC has called on all policymakers to prioritize engaging patients and people with disabilities. Today, you will also hear from PIPC members and friends about the implementation of new policies advanced by the Inflation Reduction Act and efforts to engage patients and people with disabilities to ensure that those policies reflect their experiences and what matters to them. PIPC and other patient disability experts look to PIPC for leadership in identifying and measuring outcomes that matter to patients and people with disabilities, so that research is useful for improving healthcare decisions. But even with 30 plus years of bipartisan policy precedent, recognizing that certain measures of healthcare discriminate against us, we still see research being conducted that can be used against us by payers to create barriers and restrictions to our care. Today is an opportunity to learn more about efforts to ensure that there is a consistent policy across federal programs banning the use of discriminatory measures to value healthcare. No matter what healthcare policy we are discussing, it is imperative that patients and people with disabilities that stand to benefit are at the table. We have a saying in the disability community, nothing about us without us. Thank you all for joining us today, and thank you to all the experts joining this important discussion.
Thank you for the opening remarks and your years of commitment, Tony. Now let's begin our first PIPC Forum panel discussion. We invited two people who have been in the trenches of engagement with the Centers for Medicare and Medicaid Services as they implement the new provisions for the Medicare Drug Negotiation Program and the Inflation Reduction Act. Tiffany Westrich Robertson is the Chief Executive Officer and co-founder of AI Arthritis, a group that is advancing education, advocacy, and research for patients with autoimmune and autoinflammatory arthritis. Tiffany has been working with us at PIPC for quite some time to make sure patients understand the landscape of policy changes and are prepared to lend their voices to policy solutions. Thank you, Tiffany, for joining us. Our other guest is Michael Ward, who serves as the Vice President of Public Policy and Government Affairs at the Alliance for Aging Research. The Alliance is a founding member of PIPC's steering committee and has long been a partner in our work to advance the creation and reauthorization of the Patient-Centered Outcomes Research Institute, also known as PIPC, as well as all of our efforts to ensure health policies are centered on achieving outcomes that matter to patients. So to start, our audience may be aware that Congress created a program intended to make drugs more affordable as part of the Inflation Reduction Act, or IRA. However, some people may not fully understand what that means for Medicare patients. So, Michael, the Alliance was deeply engaged in legislative efforts to address affordability challenges for Medicare patients. Can you provide an overview of the IRA's provisions for patients and help our audience understand what patients may be able to expect from this negotiation process?
Yeah, absolutely, and thanks for having me, Sarah. This is a great conversation today. So in terms of, when I think about the IRA, I think about, there's a couple of buckets. First is this set of reforms that Congress directly implemented to help patients afford their drugs, right? So we have a $2,000 out-of-pocket cap for expenditures for prescription drugs. We have an elimination of co-payments for vaccinations. We have an expansion of the CMS's Extra Help program, which helps low-income beneficiaries to afford their medicines. So those are the direct actions that really help beneficiaries. Now, in the second bucket, I think there are some provisions, which we will get into today, that are a little bit more unclear, that may have some unintended consequences that we'll need to think about, and all of us as patient advocates need to be thinking about in our own advocacy moving forward. And certainly, one I'll flag before talking about price negotiation is the Part D redesign. So payers are going to be responsible for a lot more of patient spend, especially for patients that have high spend drug utilization. And so there'll be a lot of pressure for additional utilization management, and so there needs to be appropriate safeguards in place. And when we talk about price negotiation, there's a lot of discussion about what impacts will this have in terms of access. I think it's unclear whether how this may impact access, if plans and PBMs may restrict access in some ways or move things around in formularies. And then secondly, also kind of longer term, how will this impact the research pipeline, right? How will this move incentives, perhaps in a way that's not necessarily positive in some cases, right? We need to be careful to make sure that this doesn't move incentives away from investing in conditions that would impact the sickest of us, right, as well as conditions that may disproportionately impact or cause disability.
That's a great segue to my next question then. So when Congress passed the IRA, there were provisions included that were intended to ensure that the agency engaged patients and people with disabilities. So for example, CMS is to look at whether a treatment represents a therapeutic advance or addresses an unmet need using comparative clinical effectiveness research. And this is defined by PCORI statute to measure outcomes that matter to patients and to avoid discriminatory evidence. Members of Congress spoke to their intent that patients be engaged in the process. But Tiffany, you worked really hard to identify patients who could share their perspectives about the impact of treatments as part of the CMS listening sessions on each of the drugs identified for the program. How did you identify patients to participate? And how do you think the process went for them and for CMS? Was it useful?
That's a very loaded question. So I'm going to break this down a little bit. So the first thing is, yes, we worked extremely hard at AI Arthritis. This was a unique ask because this is a different playing field now. One of the things that CMS is asking for in these negotiations is more patient engagement, more patient voices, as we know. But the level of who those patients are is a little bit unique. In the past, we've relied heavily on patient advocates or people who do this regularly. We often say the 5% of the population. But a patient advocate often speaks on behalf of others as well, right? They're looking for individual patients, often people who have never spoke publicly. They want genuine stories of impact, how these therapies have improved their lives, missing gaps, that type of thing. So that's a form of equity that I just wanted to put forth, right? Because there are subgroups in diseases. We know in typical research in the clinical trial data that's been used, for example, it's not necessarily representative of real world. So we looked at this as an opportunity. Let's really focus in addition to the people who are used to being at the table, let's also try to find people who are unique and see if we can increase the number of patients that are able to speak on this topic. So to do this was quite a challenge. I think I was working 14 hours a day to do this. So we took it a lot farther than sending your traditional email or social media posts. I made several Loom videos of me just explaining in very simple terms, hey, this is happening, this is why you should care. Have you been on this drug? And if you have, let me know. And there's some opportunities. That kept it real simple. That gave enough for people to be inquisitive. Oh, well, what is this? I have been on that drug. Okay, and then we continued the conversation. That's how we were able to secure 40% of the people who ended up in the listening sessions for both the 2 drugs of the 10 that were under our diseases. And then of those 40% of them had never spoken publicly before. And so we did feel that we at least were achieving that successfully. I do want to make a note that in addition to the listening session, CMS did also offer patients an opportunity to fill out a survey. And we often forget about that. So they did try in 2 different facets, but the survey went, I don't know, I would love to know how many people actually filled it out. It was for the public comments that they had. We filled that out as a patient organization, and knowing it was so difficult for the patient, the average patient, to even understand how to navigate that form, copy and paste your answers into it. It was not easy to do it. And in doing that, we invited them to start sharing their experiences and stories, and then we captured those in our public comments, which I think is another avenue that we can go in doing that. I did want to just say one last thing about the listening sessions. We had some resistance from patients who said, well, I didn't respond well to this treatment, so you probably don't want me. Right. And our response was quite the contrary. We're not trying to stack any kind of biased answers, because if you didn't respond, that tells us 2 things. First, it tells us that in our diseases that are heterogeneous, we know only, again, this magic 40% keeps coming up. We know that only about 40% of us actually respond to the treatments once to market because it's not representative of real world, right? So by letting CMS know it didn't work for me, but it's the miracle for the other, they need to understand that. And then the second component of that is don't stymie innovation. It didn't work for me, but I need treatments that did. So we actually had a couple people who said, I've been on 9, I've been on 10 different biologics. This one didn't work, but guess what? None of the others did either. And that tells them there's a need for more, especially when we're talking about subgroups, precision medicine, the future of matching patients to treatments and access.
Now that makes a lot of sense. I hear this story a lot from Tony with regard to his epilepsy as well. So I hear you. You know, and I'm thinking about kind of getting beyond token engagement. There are other agencies that have processes for engaging patients and people with disabilities, including FDA, PCORI. So we know that there are models out there for partnering with patients and patient groups to gain knowledge useful for research and policymaking. So Michael, I know the Alliance has experience with FDA and PCORI. Can you provide some examples of how their engagement processes may differ from what you experienced engaging in the recent CMS listening session?
Yeah, I think a lot of it goes back to what is the focus and where are patients being brought into this process, right? So when I think about the FDA and we think about patient-focused drug development sessions, patients are involved throughout that process. In fact, originally the FDA led the sessions, but now typically advocacy organizations tend to lead in conjunction with the FDA. And so it's really a hand-in-hand effort. And it's a 2-way conversation. I think that's another really important piece of that is missing, right? Because when, Tiffany, we were talking about the listening sessions and I had the chance to participate in one as well. It really was, it's kind of a 3-minute monologue, right? It's like you get up there, you're Johnny Carson for 3 minutes, and but maybe you're not really talking about anything very funny. So you're talking about what the impacts of this drug on your life, and I think that also when we're talking about the CMS listening sessions, it wasn't particularly clear to me, at least. Yeah. What CMS was hoping to get out of these sessions, right? I know, like putting myself in their shoes. I would be thinking about, what are the endpoints that matter to patients as we're thinking about price negotiation? What are the things that we should be valuing? Because as you pointed out, Tiffany, like there's so many things and points in clinical trials that, a lot of times it's geared towards regulatory approval, right? It's not necessarily geared towards all the time what's most valuable to patients, right? And so thinking about what are the pieces of real world evidence that that CMS needs to be gathering, those are the types of inputs I think that they should be trying to get, but that's not what they asked. They didn't make that ask clear. And so, thinking again in comparison to the FDA and as well as PCORI, at PCORI, again, patients are involved at every stage of the process, from design, patient engagement, studies, just thinking, throughout the entire process. And I think if CMS, had engaged with the patient community about what the patient engagement session should look like ahead of time, I think it would have looked much different, right? I think it would have been much more of a conversation that kind of met the needs of patients, because I keep coming back to the phrase that I don't think patients saw themselves in this process. And I know in my session, there was a maximum of 20 patients or stakeholders that could participate in each session. Only 11 slots were taken. And so, we had a listening session about a drug that millions of Medicare beneficiaries are taking, and we had a 35-minute listening session about what that should look like moving forward. And so I think the lesson that CMS should take from this is not that there's limited interest in from the patient community in these listening sessions or in the negotiation process, but they really need to kind of go back to the drawing board, look at what the FDA is doing, look at what PCORI is doing, look at what others are doing to get to really go and get the best practices and integrate that into the next round of discussions.
Sounds like there's a lot of opportunity there for learning. CMS has articulated that they want to improve their process for engagement as they go. But then again, the statute doesn't require much of them. And I've heard CMS say that the public may not see the justification for their decisions until 2025, which is really too late for any feedback on the evidence that they're relying on to make decisions. So I guess then my next question would be, where do you see opportunities for going beyond just listening sessions, where CMS could provide opportunities for a feedback loop for patients to weigh in as part of their deliberations? And I don't know, Tiffany, if you have any thoughts on that.
Yeah, sure. So I love the word that you used, the word opportunity, because that's really where we're looking at this. Obviously, there's a lot of confusion. There's a lot of people being even a little bit negative about the situation. But I think looking at what we can learn and take, and it's important to understand, they really are expressing interest in getting novel, innovative ways of patient engagement. I know this because I sat with them in DC in their offices in September, and I said, how you're saying this, how can we make sure that we are approaching you with innovative ideas? And they said, get 30 plus organizations behind you, work together, come up with some creative strategies, present them, and we will talk about how we can implement those together. So I believe that it's there, right? So as a team, as a community, as a national network, so to speak, we're all invested in this and uniting and being able to talk. So that's the first thing. The second thing is, I also agree with what you were saying, Michael. We didn't really know what to expect. And the thing I think I was most disappointed in was the confusion around what patients are supposed to be talking about specifically. Always patients should be involved in the beginning. That's a huge learning lesson that really has been proven time and time again. So in retrospect, you'd think that would have been incorporated. I do worry that the data, if we can call it data, that's collected, we don't know what the data points were that they were trying to capture. We know that if you don't have enough repetitive answers, you don't have enough statistically significant information. So we do question, is the patient voice a tick up the box? How can we? So I suggest and I feel that we have an opportunity to not wait until we don't know, right? I think we have their ear as a unit. We talk about how could we provide more information. I think we need to request transparency from CMS. What did you do with that information? Because you know what, the listening sessions I participated in too, one was 16, one was 11. We did not, even all that hard work, and still didn't fill all of the seats. So there is opportunity, I think, to understand what are you collecting from this, and now what is missing, can we still have that opportunity as patient groups to move forward and provide that to you? I think it doesn't hurt to ask on that. And the other thing I would really encourage us to push for CMS is that they do not rely on the patient organizations to do all the recruiting. And I kind of laughed in the beginning when you said you helped CMS. I thought, I don't know if helped them was the right word. I mean, we helped that we recruit, but I think that CMS has an enormous, this amazing opportunity. They have the distribution list right there. Like, if they would just say there's this opportunity, then maybe connect them with patient organizations who could help develop them and understanding. I just think they need to be more involved in the recruitment. That was an awful burden for our organizations to try to get all of this. There's just next time, and as we move forward, I think getting them more involved and showing them how they could actually help fill those 20 seats would be really important.
Yeah, you probably have thoughts on this too.
Yeah, I think I would second first. Smart thing to do. But I think in terms of other kind of additions to that, there needs to be, there are very, very highly advanced, very adept, patient advocacy organizations that, we're talking about the data submission period.
Mm-hmm.
That may even have registries. They didn't necessarily know what data CMS was looking for again, and like what's the information that's most relevant. I think that it goes back to the two-way conversation, right? Is without kind of having the list of what are the gaps in information that they need, what we're trying to answer, it becomes very difficult to just push, just do a brain dump and throw everything out there, especially if we're trying to do it in 3 minutes. And so, we can really focus this conversation if we're able to receive, feedback from the agency about what it is how we can be most helpful, right? Because this should come down to a partnership. Like this doesn't need to be, it shouldn't be adversarial, right? This is, CMS is a payer for older adults and people with disabilities, and we represent the populations that they serve. And so this really should be collaborative. And I know that, in other areas, including an implementation of the IRA around, the patient affordability provisions, I've had a lot of really productive conversations with CMS and talking about things that they've adopted, in draft guidance, right? And so I think, and we can get there on this too, but I think there just needs to be a little bit of the shift in the dynamic in terms of, the conversation going, having a bilateral feel to it.
Right, the feedback loop.
Yeah, right, that's right. And so I think that's going to be very important moving forward.
That's interesting. Yeah, it makes me think a lot about the feedback loop. It's communication versus just listening, right? The back and forth that's needed. And I've also been thinking about, as the process moves forward, where are the opportunities for CMS to learn about and respond to unintended consequences if patients are experiencing challenges accessing care? Is that something you hear coming up as well?
Yeah, I think we've seen this. I mentioned up front the questions around the redesign in terms of shifting more financial responsibility to insurers and how they're more likely to need to do utilization management. So that isn't like a price negotiation thing, but all of these pieces interact with one another. And an access restriction over here could impact how another provision operates and how patients experience that provision, or at least their perception of it. And so I know, especially in terms of access, thinking through, what are the safeguards that CMS needs now to ensure that patients don't see a huge uptick in inappropriate use of step therapy, for example, where they're having to fail first before they get to the medication that their provider needs, that they need in order to deal with the condition that they're living with. And so, or additional and other forms of utilization management. So I think there just needs to be an eye on all these things, and really, I would, I'm hoping that as the next couple of years that we'll see kind of a proactive move to place some guardrails around the patient experience and access, rather than kind of a reactive experience where we see a problem and then we act on it, even though we may have anticipated the problem beforehand.
Well, and getting ahead of it, Tiffany, requires your patients to be engaged, right? I mean, the people who are really out there, and if that engagement doesn't continue post-implementation, right, it seems like it'll be difficult to keep the finger on the pulse of what the impact is.
Absolutely, and I just agree with everything that you just said, Michael, and I can't help but think that I worry that we go backwards. I worry that we breathe life into step therapy, into the utilization management practices. We're moving so much, the needle so much forward into precision medicine, understanding how subgroups respond, and even thinking of CMS. I know when we submitted our comments, we talked specifically about a new subset of our diseases that is elderly onset. That's brand new. The traditional age that we've always known is 20 to 40 in adults and any age in children in these autoinflammatory arthritis. So knowing there's a 60 plus, that's their demographic largely, right? And so we really wanted them to understand and recognize too, we can't go backwards, we have to move forward when we're talking about subgroups, and again, that goes into equity, right? Because they are very adamant, we want equity included in this. They can't ignore that they cannot ignore that, right? So I think how, I don't know. I think that's to be determined, and that's going to come from all of us collaborating, all of us communicating, listening, having regular conversations with them, but it's opportunity. And I think the onus is on us to really step forward as a community and make sure it doesn't go backwards.
I couldn't agree more. That's a great answer.
Thanks.
So as CMS implements this process, we're also seeing states debating prescription drug affordability boards, and which is similar in concept. So I was hoping that you could speak to some of the similarities between these state-based processes and what we're seeing at CMS. And I'll start with you, Tiffany, because I know that you've been deeply engaged in having patients also engage in those processes.
Absolutely. And just to preface this, at AI Arthritis, our specialty is to listen and look from people with lived experience. We're all living with the diseases, the leadership in our organization, and finding the missing gaps and creating innovative solutions that build and celebrate what others have been doing, and then dive in and create some kind of program that has no blueprint. So when we saw that Colorado to start with and started watching it and participating, and then the CMS along the side, the one commonality that came up immediately was there's no blueprint, or there's not a well-developed blueprint. So as an organization that specializes in this, we sort of went, our antennas were up, right? And so one of the things that immediately in Colorado that I noticed, I was able to participate. I'm on one of the drugs and as a patient, and they had a survey pop up. And this is very in keeping with what we just said of the questions that were asked of the patient in the CMS. So you ask these questions, and one of the questions was, have you ever skipped your treatment because it was unaffordable? Have you ever skipped your treatment or spread out your treatment because it was unaffordable? These were pop-up survey questions in real time. And I stopped and said, I cannot answer this question. And they sort of looked at me and they said, there's two questions. Yes, I have skipped a drug. I have skipped a dose. And yes, I've stretched it out. It has nothing to do with price. It has to do with utilization management. It had to do with prior authorization. It resonated. So that is a big one. The questions that they're asking, it's almost like biased, because that was the same survey that went out to the people who weren't on those speaking. So they also had, similar to CMS, they had an opportunity to write in your answer. They had an opportunity for public. But if anybody on that survey online just saw the first part of the sentence and said, I've skipped, or you're just going to check yes. And it had nothing to do with affordability. So I'm sorry, but my guess is their data is skewed.
Right.
And so that also, is a concern. So that's one thing. Obviously, the underlying innovation, the threat to innovation is something that is a common thread. Also, we recognized that patient organizations and patients are really becoming two separate stakeholders. And what I mean by that is, particularly in the PDABs, I was able to participate because I'm a patient. But some of the other patient organizations who would have liked to be able to speak were not allowed because they're not patients. And it was this real eye-opening moment where I asked, how are they going to be able, other than the public comment, really be able to weigh in? There were some of the patients who gave great insight, and I was able to connect the dots for them because there's things we know as a patient organization, right? And that was a big aha moment that also connected to CMS. Was there's an opportunity for patient organizations that have never really been an opportunity to this level before, and there's an opportunity for patients at a totally different level. So I think as two separate stakeholders yet working together, that is a very important, when we're talking about diversity and patient equity and involving patients, that we have an opportunity as patient organizations to take a lead that we haven't before and push for a seat at the table. We can't be pushed out because they're looking for individual patients.
Well, and that's another lesson learned from PCORI, I feel like. I mean, this was a discussion that PCORI was having early in its development around the distinctions between patients, patient groups, consumers, right? I mean, these are different audiences, all of whom's voices are important, but but they are distinguishable because a patient speaks to their own experience.
Exactly.
A patient group has this experience with patients sort of from throughout their journey, right?
Yes.
Yeah, that's interesting.
And the patient organization can connect the dots back to the legislative issues that tie in the patient experience stories. It's a real benefit that is often not included.
Oh, that's interesting.
Yeah, I think it's like the context, right? It's the context of the patient experience in the bigger picture. And I think of both at the state level and the conversations that we're having with CMS around the implementation of price negotiation. I think we'd be remiss if we didn't talk a little bit about, the quality adjusted life year and the equal value of life years gained, right? That it's banned in the Medicare program, but a lot of states are considering using it in the PDABs, right? That even at the federal level in the Medicare program, that they're considering using the EV-LYG. There's a lot of support for that, and the comments that came from some other groups that weighed in during the comment letter process this summer. And so I think that there's a lot of discussions that need to bring this to the fore, because I know, like, even just in education around, with people that have worked with these issues, especially in Capitol Hill, for a long time, they know what the quality is. The work that PIPC has done and and member organizations have done has really moved the needle around what the quality is. But there isn't the understanding that this also extends to quality is by another name, right? And so work needs to be done there, and the work needs to continue to make sure that as we're thinking about value at the state level, that that PDABs don't adopt the quality or the EV-LYG.
It goes back to what we were talking about earlier, the ability for patients to be able to then weigh in on, if whatever information you were looking at CMS in order to make these decisions, is there a back and forth where there's an opportunity to comment, an opportunity for the people who are impacted by these policies to be able to weigh in on what kind of evidence is being used to make decisions, and does it include the patient voice, and to what extent does it include the patient voice? I think that's really important. So I'm going to just, I know we're about at time, and I just want to thank you. This has just been so enlightening. And do you have any closing thoughts before we wrap it up?
I think that there's a lot of work to be done, right? I think to Tiffany's point, there's a lot of room for collaboration, and I think we need to keep moving forward, on the federal level with CMS as we're thinking about price negotiation and the other provisions of the IRA broadly in a collaborative mindset. That there are things that they can do now to make sure that, the CMS they have a clear charge in the IRA and they have to operate within these confines, but they have the authority, they have some wiggle room to make sure that things are implemented in a way that ensure that patients continue to have the access that they need to the care that they really frankly deserve in order to treat the conditions that they're living with, to make sure that they have a high quality of life, that they're living their best life possible. And so I think just moving forward and going arm in arm with as many fellow groups as possible, developing consensus around some of these recommendations is going to be very important.
That's great. Thank you.
Well, ditto. So I won't repeat because that was very well done on that. So what I will then add on is the patient perspective, the patient voice part of it, is that I also see it really as an opportunity. This is a new wave of getting patients involved. And I think that even in itself does require some thinking differently, being creative. I just, as an example, the way that we approached this with the price negotiations and the CMS, when we did encourage people to sign up, they said, if I get picked, I'm scared. Like, what if I get actually picked? And so we gave our personal vote of confidence. We will be there with you. We will hold your hand. We will not train you because we don't think that is, I think that's biased scripting. And so we did host these online conversations where we started and we went around and we said, just don't think about the questions CMS asked. Just tell us your story. And what did you care about with that? Or why did it work? Why didn't it? And we let them talk each for a very long period of time. Then we went in, which is what patient organizations bring to the table, and we started to connect the dots for them. And by the end, they all were so confident. And they said, oh my gosh, I can do this. So I really just want to encourage a new landscape for patient involvement. That's different than your traditional advocate or the training, the preparations that we might have done before, because that's what they're calling for, is an individual patient that maybe isn't scripted, that type of thing. Let's give it to them. But we need their help to help recruit.
Yeah.
Well, thank you. No, this makes perfect sense. If the goal is to better understand outcomes that matter to patients, what you're describing makes perfect sense.
Yeah.
Well, I just want to thank you both for sharing with us your experiences and for working to identify best practices for engagement and communication with patients and people with disabilities that CMS can hopefully use going forward. We look forward to doing this together with you.
Absolutely.
Yes, thank you. So from the beginning, PIPC has been guided by its steering committee to focus its work on the issues that bring us together in the fight against stigma and bias in healthcare. The Epilepsy Foundation is a founding PIPC steering member. We are excited to welcome their new CEO, B. Martin Lee, to share with us more about her vision for the foundation.
I'm Bernice Martin Lee, President and CEO of the Epilepsy Foundation, and I go by B. The Epilepsy Foundation is a founding member of the PIPC and is excited to continue to partner with PIPC to ensure that people with disabilities do not face discrimination when it comes to accessing needed health care. We applaud PIPC's chair, Tony Coelho, for his lifelong fight on these issues. This has been exemplified through his leadership on the American with Disabilities Act, and more recently, on our shared goal of banning the use of quality-adjusted life years and other similar measures. We are also grateful that the administration is working to advance a proposed rule to update the 504 regulations to protect people with disabilities from discrimination in healthcare. Equity is a top priority for the Epilepsy Foundation. Individuals with epilepsies and their families face many challenges in their daily lives, including discrimination and stigma. Despite advances in treatment and more awareness about epilepsies and seizures in the last decade, there is still stigma and misunderstanding about this neurological condition. People with epilepsy often feel marginalized and discriminated against because of the misinformation that surrounds epilepsy. This can lead to poor health outcomes, including difficulty with diagnosis, and even failure to follow a treatment plan to control their seizures. I live with epilepsy, and I have experienced stigma and discrimination because of my epilepsy. I experienced my first seizure in college, and it was dismissed, and I was told that I was just stressed. And after a 2-year journey to diagnosis, I was placed on Dilantin, a medication that greatly diminished my quality of life. I told my neurologist that I just simply could not exist on this medication. And his response was that I could go on long-term disability, as I was likely on other types of government assistance. I was a high school teacher at the time. While in the workforce, I had a breakthrough seizure at work. And after being cleared by my physician to drive, I was told by my employer that I was not able to park in the parking lot because I was now a liability. I had many incidences of stigma and shame because of my seizures. But my story is just one of many stories in our community. There are numerous people who have felt the stigma and discrimination that an epilepsy diagnosis brings. All people with epilepsy, just like all people with disabilities, have immense value and deserve the same access to needed health care. The Epilepsy Foundation is working to remove barriers to care and increase community and clinical linkages to existing epilepsy resources and treatment. Health equity isn't just an aspiration. It's an imperative that demands actionable steps. It is about dismantling the barriers that prevent a breakthrough in new epilepsy therapies from benefiting all members of our diverse community. The Epilepsy Foundation's role is not just to bring attention to these disparities, but also to drive a movement of meaningful change. We thank PIPC for the opportunity to share a little bit about what the Epilepsy Foundation is doing on equity. We look forward to working with PIPC and all of its members because we know together we can ensure that all people with disabilities can access the care that they need and deserve. Thank you.
Thank you, Bernice. Our next discussion is focused on the hot topic of value assessment and its use by payers to make health decisions. It is no secret that the Partnership to Improve Patient Care is a strong supporter of protections that were included in the Affordable Care Act that bar Medicare from using quality-adjusted life years, or QALYs, and similar measures to make decisions related to coverage and reimbursement. We share the concerns expressed by many disability and patient advocates about how value assessments devalue disabled lives and fail to represent what patients and people with disabilities most value in terms of their own quality of life. Today, we welcome two people who have been leaders in advocating for protections against the use of evidence that is biased or discriminatory to make health decisions. Rich Brennan is the Vice President of Federal Affairs for the ALS Association. He helped to lead their work with the Institute for Clinical and Economic Review, or ICER, an entity that is advanced value assessment for new treatment of ALS. He's also been a tremendous ally in educating policymakers about the flawed methods used by some academics to value healthcare. We also want to welcome Anna Fidua, the Manager of Government Affairs at the National Down Syndrome Society. Her organization has led efforts on Capitol Hill to extend the existing ban on QALYs and similar measures in Medicare to other federal programs. Thank you for being here. Anna, the National Council on Disability led the way in identifying how QALYs and similar measures lead to discrimination in our healthcare system with their 2019 report. Can you connect for us how the NCD recommendations were received on Capitol Hill, and tell us a little bit about the legislation that was considered earlier this year in the House?
Yeah, absolutely. I think it's really important to start by sharing that since this report was released, the disability community has really built a consensus around it and has really amassed broad support. There was over 100 disability organizations and more counting every day that are really bringing this issue to their communities, but also to Capitol Hill. So understanding as we kind of take this issue to the Hill, right, this is something that our community, at least, is really has broad support around. And so, then we look to the Hill, the Protecting Healthcare for All Patients Act, or HR 485, which was taken up by the House Energy and Commerce Committee earlier this year, would do exactly what we think is necessary, exactly what you just touched on, right? We have these protections already in Medicare through the ACA, but I think specifically for the disability community, Medicaid is really the primary insurance that most people with disabilities have. Specifically, actually, a really fascinating report just came out of JAMA about the Down syndrome community specifically and how vital Medicaid is for individuals with Down syndrome. So while you're very obviously supportive of the ban in Medicare, we really saw that as kind of one first step in this bill, building upon that to ensure those protections are included and more robust across all federal programs. So we were, of course, very supportive of the bill alongside many other disability and patient advocacy groups. Our president and CEO, Candy Pickard, actually testified in support of the bill at markup, and very personal issue for her. She has a young son, Mason, who has Down syndrome. And so understanding, right, the ways that this issue is really impacting our community, I think, one example I could even just throw out there that she really touched on in her testimony is around Alzheimer's disease. Individuals with Down syndrome have an incredibly heightened risk of Alzheimer's disease. It's upwards of 90%. It's actually the leading cause of death for individuals with Down syndrome. And we know that in some initial coverage determinations from CMS around Aduhelm, this groundbreaking new Alzheimer's treatment, they're using reports that utilize QALYs and really rely on QALYs to inform their decisions. And the result of that was that our community was completely excluded from this entirely groundbreaking new class of drugs. So I say all of that to kind of, really in our advocacy on Capitol Hill is it's personal for a lot of our community, but we're seeing the impacts play out. And so when we're advocating, again, it's that expansion, it's that building upon protections, because we know they're important across all federal programs. And I think that the issue itself has had a long history of bipartisanship. We've seen support on both sides of the aisle across different administrations. And so a lot of our work now is that educating and talking to members in their offices and really kind of illustrating for them how real this issue is. I think in our experience, when you really sit down and take the time to understand it and pick it apart and see the impacts, members and their offices tend to really agree that this is wrong and are shocked that these are the types of metrics that are informing our healthcare system. So I think, from the report to where we stand today, it was really, okay, how do we take this knowledge that NCD has really brought to light, but that we know has been happening and we've seen the impacts of, and educate members of Congress to support this bill, but also to understand all the ways in which value assessments impact our community.
I was excited to see Candy testify. I actually have a dear friend whose sister was part of that population that had early onset Alzheimer's with Down syndrome. So anyway, it's nice to hear your organization really raising the profile of that issue. And I know Rich, the ALS Association, also supports HR 485. Can you connect the dots and tell us more about ALS and where you've identified flaws in the recent value assessment process for a new treatment?
Certainly. First of all, Sarah, thank you for inviting us to be part of this panel. It's so important to help to educate not only policymakers, but also the general public about the detriment of these types of measures and how they can affect their access to anything conceivable, such as the drug therapies,
right.
Access to care services, access to durable medical equipment that is actually medically necessary durable medical equipment. That's what happens for an ALS population. For somebody that needs, in order to survive, because they have reduced lung function, they can't breathe without a respirator, they can't move around without a power wheelchair system, they can't speak without a voice-assisted device. Those types of factors, and even extending their life, trying to understand, do I have access to a new drug therapy? Those types of decisions are made by both the patients and the family members of ALS all the time, and they're limited resources. And we're talking about decisions that are made by, I guess, in-name organizations that you say that the Institute for Clinical an economic review. Well, that sounds like so, prominent and good, but really their decision making and how they approach their pricing methodologies and the use of qualities in those decisions really does have an effect on patients. It really does have an effect on the family members, and they suffer the consequences of these decisions.
Can you tell us a little bit about the data that was used in the assessment in terms of how they measure quality of life and impact on improving quality of life for different subpopulations of patients? Because, we think about the quality as, between a 0 and a 1, a patient will, or people with a certain condition, right, will fall somewhere in between in terms of the value of their life and then how, or the quality of their life and how much a treatment would improve it. So having that information about what matters to patients, what their experiences are on treatment in terms of their quality of life is so important, but I know there's been some critique of ICER in terms of how they measure that.
And that's the problem with qualities, is none of that is measured. None of that is taken into consideration. But what does happen is, and this is our experience, because ALS, even though it's a rare disease, we have had the benefit of having some new therapies actually approved by the FDA as of recent. Last year, in combination with the consideration of our new therapies, ICER decided to do a clinical review of 2 therapies that are vital to be able to extend the life of those with ALS. And their review was done with qualities. It was also done with data that was derived from UK and Korean data. So nothing that would have to do with United States data. The data was about 10 years old. So there were a variety of things that were done in order for them to make their decision that wouldn't make any conceivable sense. In other words, I'm not going to interview anybody and determine what it means to have ALS and make that part of my decision making in the evaluation of these drugs. Instead, they placed the evaluation of these drugs and actually decided that they were not cost effective. The consequence of those kinds of decisions, by having an official report come out from this institute, is that insurers can look at those reports and make determinations on whether or not they are going to cover those on their formularies. If our values are, as Americans, to have access to these drugs as soon as they are available through the FDA, and that's what we believe, there shouldn't be any way of standing in that way and saying that indeed we're going to make determinations of people and decide that indeed, because your life is reduced, because you have a disability, because you have less than 2 years to live, that we're not going to provide access to any conceivable therapy. So,
it flies in the face of the whole purpose of the drug approval process, it seems.
It does. It puts economists in the way of the decision making that should be made. Now, with qualities, for instance, it's sort of like a seedbed where it can then make its way into any conceivable decision making process. So whether or not it finds its way into somebody saying, well, we have this prior authorization process because we have this evidence over here, this report that they put out that allows us to restrict a drug in a certain, respect. So we run into that. We have to constantly, our association is constantly trying to react in battle for access to these new therapies, because insurers are looking to these entities to make their decisions. And in some respects, it gives them a little bit of a political cover to be able to make these decisions. So we're totally against the ability of someone to use metrics that are discriminatory and that reduce access to to these vital health services. So, yeah.
Well, it's striking to me that patients that are not even from this country were potentially used then as part of that measurement process, and that's very troubling. And so, Anna, I know we so appreciate the society's leadership in advancing the Protecting Healthcare for All Patients Act, which bars any measure that devalues people with disabilities. And both of your organizations have raised concerns about similar measures used in value assessment, including one called the Equal Value Life Year Gained, or EVLYG as some call it. I noticed that those concerns are shared by many in the disability community. And can you share more with us about what that measure is and why it's so concerning? I'll start with you, Anna.
Yeah, absolutely. I think we're concerned about that specific measure for a number of reasons, one of which being, and really a lot of this coming from the knowledge that the NCD report provided, was that that measure was never intended to be used as a supplement for QALYs. It was never developed to be a replacement. It was only developed to supplement it and to allow, be used in addition to QALYs to measure life extension. For people with disabilities, life extension is not always the goal. It may be, and it's perhaps important to some, but quality of life and the value that they may get from these treatments and these therapies, for many is far more important. And so what we really saw that was very concerning with this specific measure is in a lot of the conversations it was, well, let's codify this specific measure as one that can be used. And we said, well, hold on, that's just kind of adding one bad metric in the place of another bad metric. And again, one that was never intended to be utilized in that way when it was developed. And so, that specific measure by name is something we're really concerned about. I think as a whole, though, going back to this belief that we also just oppose these value assessments in every form that they exist, one metric or another, whatever name we want to call it. And we really see the goal being prompting HHS and health economists and researchers and other stakeholders to come together and find a solution that works. Because as of right now, the understanding is there isn't one metric, right? It would be easy if there was one thing we could point to and say, well, this will completely eradicate discrimination and also make sure that healthcare is cost effective. I think if we had that, right, that's what we'd be advocating for. But the understanding now is that that doesn't yet exist. And so instead of, maybe spending time on the merits of this measure versus that measure, when we know they're all flawed, is let's all come together and better understand and make sure people with disabilities are included in that, and the chronic illnesses and the elderly, right? Making sure these patient voices are heard, and let's find something that does work. Because of course it's important to have cost-effective healthcare, of course. But it needs to be accessible as well, and it can't be accessible if it's discriminatory. So we're really concerned about this one metric, and especially any kind of step towards codifying it or including it in any form of statute or regulations, because again, it has some problematic pieces at its core. But I think again, it's that it's going to take a little bit more than just putting in one metric or another. I think it's really going to take people coming together and finding a solution that works.
It's a good point that the EVLYG, at least to date, because it's a measure that was created and implemented by ICER,
right.
We've only seen it as a side-by-side with the QALY. It's
right.
never been used or indicated for use as an independent measure. So that's,
Absolutely.
that's a very good point. And you must have had this in the ALS report.
Yes, we covered that in our against EVLYG as well. The point being that even though it's a supplementary measure, it doesn't, well, let's put it this way, it is completely lacking in any informative evidence of what patients want as far as their quality of life, how they perceive quality of life, and also determining what economically is feasible in a household to be able to attain, how do I afford these costs? So any of these measures that have been sort of think tanked by industry really need to be scrutinized by CMS, and that's what we're calling for. Is yes, we need bans, but we're also in recent comments that I could easily share is that we don't understand, even if you were to necessarily have this ban put in place, we need evidence that there is actions that are taken to ensure that these don't find their way into other methodologies. So this is more than just sort of how we approach whether or not we're going to decide on the price of a drug or the price of a durable medical equipment. It really does come down to, and this has been captured by the recent Section 405. They're changing the Rehabilitation Act to 1973 to update this, to make it in line with the Olmstead Act, which is a Supreme Court decision. They're making it in alignment with the ADA, because we need to be able to make sure all these laws are providing adequate protection for people with disabilities across the continuum of care, and that that is what is important. Now, the problem is that we also have to agree as a society that discrimination does exist in our healthcare system, and that's the reason we need to have these protections in the first place.
That's such a good point. It's such a good point. I think that the looking at how we measure both life extension, quality of life, and one of the most concerning aspects of the EVOIG is that it just doesn't capture quality of life improvements, which I know has been really troubling, particularly for disabling conditions that are where we were measuring the impact of treatments. And so I'm glad you brought up the Office for Civil Rights. We know that recently the Office for Civil Rights proposed to restrict the use of value assessment in decisions made by recipients of federal funding, which includes Medicaid programs. And I noticed that several of the written comments from the disability community argued that the potential for discrimination goes beyond how these studies measure life extension. And so the ALS Association's comments, I thought, went into great detail on this. And there were several others that commented on the proposed rule, that value assessment in terms of discrimination goes beyond, the problems go beyond life extension. So I was hoping that you could talk about other ways in which value assessments may fail to represent patients with disabilities, people with serious chronic conditions, outside of just this life extension piece. And I think we touched on sort of the quality of life and piece, and then also picked up on the international, using the wrong representative data, because I feel like that inherent bias and the flawed data, these are also all components. I don't know what else you may have seen in some of the work that you've done.
Go ahead.
Yeah, I think one issue that is also, kind of top of mind for us, one of our legislative priorities that illustrates this, is in the organ transplant system. So also in 2019, NCD was really busy. They released a report around organ transplant discrimination in the disability community, and found what we already knew to be true through our anecdotal experience with our community, but really found research that showed that individuals with disabilities face many barriers and are widely discriminated against in the organ transplant system. And there's a lot of different things. There's this kind of idea that individuals must be able to independently comply with post-operative care, which is crazy, because can anyone independently comply after receiving an organ transplant, right? Just implicit bias, these assumptions about the quality of life with an individual with Down syndrome and or another disability. And so, all of these kind of compounding factors that would lead a healthcare provider to make the decision that an individual is not worthy, that their life doesn't have value, and therefore they should not receive an organ transplant. And I guess this is perhaps a little bit of a life extension conversation, but it's really a your right to live conversation,
right.
and if you are going to survive or not. And so it really becomes this concerning issue, and there's this lack of transparency around how those decisions are made at the provider level, at the donor level, right? And all of this kind of very confusing, hard to navigate system. But I think it boils down to, as it really speaks to, right? There has been some signs that perhaps QALYs do play a role in some part of that system and of those determinations. But even beyond that, providers are still discriminating against individuals, or individuals still aren't receiving access. So I think it speaks to this kind of larger, right, and in our approach to these changes through 504 is, this is great, but to your point, how are we making sure that we're not just writing things, that these things are actually happening, they're actually impacting the lives of people that they're supposed to, and understanding this discrimination, again, it's not as easy as I think some may think it is, right? Oh, if we change this one rule, or we stop using this one thing, discrimination will cease to exist. And I think it's broader than that. It's this getting to the heart of, right, these assumptions and these kind of societal beliefs that some may have around quality of life and the lives of people with disabilities and chronic illness. And I think that one kind of issue really illustrates that we do need federal protections. We need more than just regulation. Regulation's great, but specific case with organ transplant, we champion a bill around organ transplant discrimination, but kind of bringing it back to the Protecting Healthcare for All Patients Act is we really do need these protections to ensure that they're expanding and that they're continuing to be championed by our elected officials and not just left to regulators to, hopefully fix, but that they're more
regulations
robust.
can be changed.
Exactly.
Yes. But laws are much more difficult to undo. So
Exactly.
I'm with you. I think that, and the National Council on Disability, I think, did a really good job in their recommendations of saying we need a consistent policy.
Right.
I mean,
right.
they very much noted in their report that there is a lack of consistency across all these programs, and
Absolutely.
so that creates, I think, some confusion, at least in my
Absolutely.
mind. So I don't know if you have anything.
And Sarah, what I would say also is you had talked about the data, the fact that we don't have real-world evidence and we don't have evidence that's built on patient preferences, and patients have been, because we're an advocacy group and we involved ALS advocates in everything that we do, we want to make sure that there are opportunities to be able to have them at the table, to be able to be with their policymakers. And so if the decisions are being made on Capitol Hill, they need to have informed opinions based on what the patients want, what those people that are on the front lines need. If it's being policy that's being made by HHS and CMS, then indeed there needs to be ways to inform that policy with a patient-driven efforts.
Exactly.
And so without that, we're really at a non-starter. We can't move forward without having a more transparent system. We can't move forward without having checks and balances in place. There are a lot of things that are just needed, and we have such a complex healthcare system to begin with that we almost need to sort of strip things down and streamline things and start maybe a new way of doing things to ensure that people really, if we're talking about a system that can care for people, well then let's build that system. So because we have
Right.
The ability to spend, we have the ability to necessarily make a difference in how that money is being spent. We have tremendous efforts underway to ensure quality of care across the continuum, to use technology in new and innovative ways. Why can't necessarily we, instead of being siloed, and I approach it this way, I approach it this way. Let's get some commonality and especially get all the patient advocacy groups together to say, indeed, we're stopping this here. We're starting with qualities, but we're going to move on from here.
Yeah, I couldn't agree more. It's interesting. We think about what we're dealing with on the payer side with quality adjusted life years, and then if you take it even further back with research. It makes me think about the NIH, right? They've been working to eliminate the ableist language in their mission statement, which I think is a wonderful effort that people are supportive of. Yet when we talk about the health utilities that go into calculations of quality of life, I think about this measure called the EQ5D. The first question talks about what is your ability to walk about and rank it, right? And that's one of the measures that goes into your quality of life. I know a lot of people who aren't able to walk about who would measure their quality of life as quite high. So talk to us about quality of life or the value of the quality of life improvement as might be described in that kind of generic measure, and how that might differ from people who live with ALS or Down syndrome.
Yeah. I think it's really, it's incompatible, right? And I should say, the NIH, again, it's wonderful that they've included this, these steps towards this language. They also very recently included the disability population as a health disparity population, which has opened up research and support. It's fantastic, right? And so I think in that it's understanding, right? This is credit where credit is due. These are great steps, but they're only steps, because then we take one more step forward and we say, oh, well, wait, but then you have this other thing over here that says this. And I think it goes back to Rich's point he just made is, if you asked an individual with Down syndrome, how would you quantify your quality of life? They're going to tell you things like their family, their friends, the satisfaction they maybe get from a job or a hobby or going to school, right? That's very incompatible with the way that our healthcare system is quantifying quality of life. And so I think it's understanding, right, how do we kind of bring these people in and find the happy medium and find where we can both have data that is useful to a healthcare system that at the end of the day has to function, has to be funded, has to, reach certain goals, but who serves the people who really need it. And I think, again, for people with disabilities, looking at a list that asks them all these questions is perhaps really irrelevant to what their actual life looks like and what they need from a healthcare system to improve their life. So I think it's, again, I couldn't agree more, making sure those people have a seat at the table and are able to help inform those decisions. And instead of having to fit into this very narrow, arbitrarily defined idea of what is a high quality of life, being able to express just kind of the totality of what a fulfilling, healthy, high quality of life can look like.
And it must be largely informed by accommodations, right? You talk about DME and...
Oh yeah, I mean, conceivably, if I took you through the journey of somebody living with ALS, it takes 15 to 18 months to diagnose. So it's a really difficult diagnosis. People start from the time of indication of this disease. You have 2 to 5 years, Sarah, till your end of life. So think of it in this terms. When we're talking about qualities, we're talking about other measures, when they're saying that they're built on people that are healthy, right? Mm-hmm. So if I were to say, I could extend your life by 10 months, you're a healthy individual, what would you say? Okay, that sounds great. I can, sure. But I'm planning on living until I'm well into my 90s, right? Everybody's in the papers seems to be dying about hundreds of mark right now. But in somebody who has ALS, if I ask that same question, what would you do if you know that you have 2 years to live? Does 10 months make a difference to you?
Well, it does if it's,
That's doubling your lifespan at that point. So, and then think about in those terms, like if we can deliver a therapy, not only that extends their life, but changes the trajectory of what they actually go through. It might mean that their progression of their disease slows. Mm-hmm. They might be able to walk a little bit longer. They may be able to keep their voice a little bit longer. Yeah. They may be able to, communicate with their loved ones and enjoy a quality of life. And I would say that in everybody's ALS journey is different, but the fact that they are completely dependent on others and technology around them builds this tremendous relationship within this dynamic of their network, and they get enjoyment out of that.
Yes.
Their lives are still enjoyable even in a state where they are completely debilitated. So we have to be able to measure life in different terms and make decisions for those that are in need in not only a sort of like a rational way, but also informed by what their preferences are.
That makes it striking because, we talk about research. It strikes me then that each population is different, right? And each disease or condition is different. And so, I'm just thinking about how, in terms of your final thoughts, what would you think about how researchers can better capture those outcomes that matter to patients in value assessment, but do it in that kind of nuanced way that it's really, it's about ALS or it's about Down syndrome. It's not these generic types of measures. It seems like we need to be conveying to the research community the importance of the data that's specific to your populations so that we're doing this better, right?
Yeah, it's a great question, and it's a hard issue, right? These are hard issues. I think it's twofold. I think absolutely, everything we've said, again, just want to reiterate, if anything comes out of this, there has to be a seat at the table for the people who are experiencing this day to day. Researchers have to partner with people. They have to seek to better understand and use the data. Frankly, sometimes that data doesn't exist, right? That we're not even, and again, why it's so important that these continued research expansions and inclusions are so important, but seeking out where are the gaps in our knowledge to really fully understand and partner with these communities. And then I would kind of turn it on us too, right? It's a little bit on the disability and patient advocacy communities to come together on these issues and say, this is important, and maybe there are differences in the way our communities are impacted or feeling, but we know that there's problems, and so how can we all work together in this collaborative manner with researchers, exactly to your point, to say, well, you know, people with Down syndrome may experience this differently or need some sort of maybe different approach, but at the end of the day, we can all agree that what's happening right now isn't working. And so, you know, how can we move towards a better system that is more compatible with each of our own individual communities, I think is important.
And I would say that I believe and I believe in the role of institutions. I'm not trying to say that there isn't a role for thoughtfulness in what we do. I would, you know, reiterate the fact that, you know, yes, the patient advocacy groups need to find ways to partner with these institutions and find out ways that we can be better informative of their decision-making processes. So places like PIPC, you know, that are very now thoughtful places to necessarily trying to develop measures that are patient-informed and that really survey broad patient populations and saying, what are commonalities that we necessarily can capture to say that there is a trajectory of things or a level of services that would be demanded by, you know, a patient population. Try and, you know, have these conversations not only inside the Beltway here in Washington, D.C., but we needed to hear from across the country and understanding, you know, what are people's preferences. So this shouldn't all be baked here in Washington, D.C. We really need to have this state-led as well. And those state innovators that are concerned about these things, yes, they need to make a difference and be able to shore up their laws and their protections as well, and also be thoughtful on how they are conceiving, how do I take resources and make them available to these vulnerable patient populations, whether they're serving a Medicaid population or a Medicare population. We really do need to move forward on this.
Well, this has been really enlightening. Thank you so much. I appreciated this conversation, and I'm sure our audience does as well. You know, we look forward to hearing more about your efforts to change the value assessment landscape in 2024 and beyond. Thank you for sharing your insights with us today. And we look forward to hearing about your efforts to change the value assessment landscape in 2024 and beyond. Thank you. In a moment, we will hear from Dr. Bonnie Sweener with Johns Hopkins, and look forward to that discussion. For our final conversation today, I'm excited to welcome Dr. Bonnie Sweener, the founder and director of the Johns Hopkins University Disability Health Research Center. Dr. Sweener takes a data-driven approach to advancing health equity for people with disabilities. Some of you may remember that PIPC's chairman, Tony Coelho, was very vocal about the need for people with disabilities to be designated a health disparities population by the NIH. Dr. Sweener served on the advisory committee to the NIH director that made that recommendation. Dr. Sweener, it's been a pleasure to get to know you. And as you and Tony have collaborated on so many challenges related to advancing disability-focused research and data collection, I'm glad everyone watching is going to get the opportunity to learn from you and all the ways that people with disabilities have to fight just to be recognized in the research literature. Tell us a little bit more about yourself and what this recent NIH designation means for people with disabilities.
Yeah, well, it's a pleasure to be talking to you and to be working with you and Tony. This designation is a huge deal. It certainly has been a long time coming, and it opens the door for more funding to address the health inequities that we know people with disabilities face, and to support the inclusion of people with disabilities in the research workforce. Up until now, there has not been opportunities to get that funding without that designation. The other important aspect is it means that people with disabilities will have the opportunity to be included in critical community engagement efforts from the NIH. During COVID-19, people with disabilities weren't part of those efforts, for example, but now with the designation, they could be.
Wow, the connection between both disability researchers and driving more people with disabilities to be researchers in this designation is an interesting connection. At the same time that NIH was debating this decision about the designation, the agency's also been working to amend the ableist language in its mission statement. So what do you think led NIH to take that important step, and how do you think it's going to change the NIH culture of research?
Yeah, well, the suggestion to revisit the mission statement actually was one of the recommendations from that committee you mentioned in the opening that I co-chaired. And our committee had much discussion about the mission statement, which includes currently language about eliminating disability. And there's a lot of nuance to discuss and think about, and difference within the disability community around views of that concept. But our feelings were that by changing the mission statement to be less ableist and to remove that language of eliminating people with disabilities, it would make a really clear statement that NIH was taking a different position, and an important statement to the biomedical research community that largely doesn't think about people with disabilities the way that we think about ourselves.
Yeah, that's a very good point, and it's interesting to think that for so long the NIH has been operating with language in its own mission statement that was, could potentially have that sort of implication for its entire culture. So, I'm then now thinking about from a disability data perspective, how we look at people with disabilities and determine who has a disability in terms of our U.S. Census. And so I know that Tony actually served as the chair of the Census Monitoring Board in the late 90s, something that he's very proud of, but that also makes this issue of the census very near and dear to him. So I remember that the disability community 10 years ago when we were talking about this had pushed back on those census questions. And I know that, or at least as they had been recommended at the time, and that there are many in the community that think that those questions could be strengthened as opposed to weakened. Can you tell us where things stand now, and why are the questions important, and where's the tension in terms of what we have now, whether they should be weakened or strengthened?
Yeah, so this is a timely question. Right now the census is considering changing the disability questions. And in my view, and I think of many others, the proposed change would weaken the data being collected. It actually would cut the prevalence of disability by 40%. And that's important because the data that the census collects informs resource allocation, informs all sorts of policy decisions. And when you cut the prevalence of a population, that means less, right? Less support, less effort, less advocacy could potentially go behind people with disabilities. To your first point, the current questions that are in place are actually not ideal either. And so there has been a pushback that myself and others have made into asking census to not move to questions that we view are worse, that would cut the prevalence of disability or the count of the number of people with disabilities in the US, and instead engage with people with disabilities and develop better questions that better reflect how people with disabilities view themselves and collect data that matches that. This proposed change that's being moved forward has largely occurred without community engagement, and that's simply not okay.
You said to me once, it's the difference between engagement and communication.
Yeah.
Which I now have stolen from you, because I think it's such an important point, and it's a point that seems to be made throughout the discussions that we've had here at our forum today, is the need for not just engagement, not just listening, but this sort of bilateral back and forth feedback that allows everyone to learn from each other and what they're trying to do. And it sounds like this is an area where that kind of communication may be lacking.
100%. In conversations in public forums, folks from the Census Bureau and others working on this change from the federal government have gone through appropriate channels to enact change. But those channels are not engagement. They're putting out requests for information in Federal Register, and that is not accessible quite often. The details provided aren't very clear to many unless you're really deeply entrenched in these issues. And that's not an opportunity for two-way information sharing like you're describing. Community engagement is meeting people where they are and humbly coming to those conversations, both sides wanting to learn. And what's occurring now is exactly what you said. It's disseminating information.
Right.
And I think this day and age, we are at a place where we know the research we do, the information we gather, the data we collect needs to be grounded in the views of the communities we serve. That requires engagement and not just communication.
I couldn't agree more. I know when the Patient-Centered Outcomes Research Institute was created, the goal was that there would be a model for that kind of engagement, so that makes a lot of sense. I'm thinking now then too about, PCORI, right, was one of the first, they were the first to designate people with disabilities as a health disparities population. So, they certainly have bragging rights in that regard. But then, also thinking about the 504 rule. And, I know people within the disability community were really happy to see the HHS Office for Civil Rights advance the proposed 504 rule, which covered a whole range of issues related to non-discrimination in healthcare. It's a big role. I wanted to focus on this section on value assessment, though, for a moment, because I think that's another place where this engagement piece is really important. Many disability organizations commented that the final rule should recognize how this kind of research may be discriminatory beyond just how it could discriminate in the context of life extension. And so as a researcher, I'm curious how you see bias seep into research and the survey data. There have been so many studies now talking about public bias that seeps into survey data. And that's the kind of data that then forms the health utilities that are used in the measurements on value assessment, right? So it's all kind of comes around. How do you see this playing out maybe in your work?
Yeah, it's such an important point because the bias happens at every stage, right? The bias happens at the development of the study or the survey. Who gets to be in the room and who holds the power to decide what questions are collected, what populations are engaged, what strategies are used to collect data. And quite often, they are excluding people with disabilities in direct and indirect ways, not making them accessible, for example. And then the questions that are used, such as the current metrics of quality of life, have been largely built on ableist assumptions. And the people in the room and the people that have gotten opportunities to be researchers have largely excluded people with disabilities, right? Those systems and structures have squeezed out so many disabled people from being in those spaces of getting to be a researcher. So the people doing that work in and of itself is biased, right? And so all of those things compound, the people designing the studies, the people developing the metrics, to create this whole mass of bias that hasn't been pushed on. And quality assessments, quality of life assessments is a prime example of that. The idea that people with disabilities have a lower quality of life has largely been unchallenged in research settings. And a lot of that is because of this lack of community engagement and community partnership and the fact that there's so few people with disabilities as researchers and in these positions of, quite honestly, power in research settings.
Yeah, how do you change what these researchers are taught in school if you don't have people with disabilities in those schools?
That's right. And not doing outreach to include and value the views of advocates and people with disabilities in the community to inform
Right.
the teaching and the education, right? Again, that's a partnership and engagement approach.
Yeah, it all comes around to, it's interesting, the NIH decision to include people with disabilities as a disparities population potentially has so many downstream impacts that could be very, very positive. So that's a really good point. I've also heard CMS talk about the need to better collect data on people with disabilities in their demonstration programs. It's a topic I've heard come up in conversations with CMS a couple of times. And they've noted that they may have the data that shows a person has a disability, but it doesn't necessarily show what disability or give them enough information to know how to accommodate it. So do you have any ideas how CMS could do better? Because I know this is an area where CMS actually seems to want to do better, but is struggling with figuring out how to do it.
Yeah, so right now, the collection of disability data and what I would imagine, or what I view as a gold standard, is having patients, individuals, respond to questions as part of their demographic section in electronic health records or in health record forms about disability status. It's not there. So we're not collecting disability in all the same places and ways we're collecting age, race, ethnicity, gender identity. Information about disability is largely assessed by healthcare providers. And that in and of itself can be a bias. So what needs to happen is there needs to be a shift in the way we're collecting that data, and it needs to be standard. So it needs to be happening across the board in healthcare settings. We talk about it at my center as collecting disability on all places that we are collecting other demographic information. In healthcare settings, electronic health records is one example. There actually has been some progress. So at the Office of, the Office of the National Coordinator.
I know, I get that one wrong all
Health
the time.
Information Technology.
Yes, ONC, as it's so lovingly referred to.
Right.
Yes.
Megan Morris at the University of Colorado, in partnership with Sylvia Yee from DREDF and myself, gave a presentation, I think this was now a year and a half ago, about recommendations to do just what I described. Yeah. And that has moved forward and now is at OMB for consideration. For regulation of collecting disability as a required component, disability data, as a required component of electronic health record capture. That would open the doors and allow opportunities to finally look at health inequities, healthcare inequities that people with disabilities face, to understand if people with disabilities have worse outcomes, are at greater risk for negative consequences of different types of surgeries or falls, or all the metrics that we're looking to assess healthcare. We just can't do that for people with disabilities without the data.
Well, and that's very important for inclusion. There's so much evidence out there about people with certain conditions that doesn't necessarily include or distinguish the impacts on people with disabilities. So that's a really good point.
Yeah.
Well, thank you. I really appreciate all of your insights about how to advance disability inclusion and research. And I would, love for us to stay in touch and to stay abreast, because I feel like so much of the work that you're doing, I think, is very much connected to the work that the patient and disability communities are doing around value assessment and just inclusion of people with disabilities and research broadly. It's all connected, but thank you.
Thank you. No, I couldn't agree more. I think that research is better when we work in partnership with people with disabilities, with advocates, and with the community. And I hope we do much more of that.
Thank you. Thank you so much for being here. I want to thank everyone for joining us today at PIPC's annual forum. While we always want to be with you in person, we're also fortunate to have this opportunity to meet you where you are. I hope that you found today's program inspires you to learn more about PIPC's work and to join us in our advocacy to improve healthcare by ensuring patients and people with disabilities are engaged and at the center of it. We want to hear and learn from you, so please reach out to us at pipcpatients.org. Enjoy the end of 2023, and we look forward to seeing you in 2024.